minutes. I'll finish off fast. So, distal blocks at elbow and wrist. Am I looking distal blocks at elbow and wrist as rescue block? No. I think the answer is no, because somebody asked me that you are doing fellowship in regional anesthesia, then you must be good at rescue blocks. The answer is, when we are into regional anesthesia, we do our primary block in a right way, and we actually don't need rescue blocks. If at all, if my junior resident is performing a block and I need to do something about block, then with ultrasound it is very easy nowadays to have a second look and identify what the problem is. What are the indications then? Actually, do we need these forearm blocks? Yes, we do need. We are in era where initially 10 years back, it was more of a opioid dominant days where we used to treat all our patients for post-op analgesia with morphine. Then we are into central neuroaxial catheters, epidural. Slowly we moved away into the peripheral nerve blocks, and now more into distal blocks, adductor canal block, and LIA, local infiltration analgesia. The same analogy can be applied here when it comes to forearm blocks. So the important indication for these blocks is daycare anesthesia. I would like to ask you one question, like, if my patient is for unilateral TKR, why I need to block both limbs? So slowly we moved from epidural to sciaticofemoral block, and now we are more moving into distal blocks. So nowadays, when we think of TKR, we have a single shot spinal with distal sciaticofemoral block, maybe adductor canal block with LIA, local infiltration analgesia. So the same logic, if I apply it to upper limb, then I can think of giving a spinal in form of subclavian perivascular. Subclavian perivascular is called as a spinal of upper limb. And then, because with short acting local anesthetic, because my surgery is under tourniquet, and at the end of surgery, I'm giving a dedicated forearm block. So this is similar, which is providing a better quality care. Fast tracking and early discharge is necessity of time. Safety, yes, it is very safe, because it is not a good idea to have a absolutely paralyzed and numb limb and patient getting shifted from OT to ward. There are few case reports where there were accidental shoulder dislocation and patient were not able to protect their limb properly. So why I should be paralyzing cause a motor block when it is not required? Pediatric patient is one of very important aspect as far as this block is considered, where patients are under general anesthesia and they are done for better post-op care by doing a dedicated block with ultrasound in forearm region. Adult block under general anesthesia, yes, an important indication. Now, why these distal blocks at elbow have fallen in disrepute in pre-ultrasound era? If you read any standard textbook, like for example, Admir Hadzik or Brown Color Atlas, they have criticized these blocks in their older edition. The important reason is difficult to perform, more time consuming, uncomfortable to the patient. Anatomically, the nerves at elbow are contained in bony or tight ligamentous surrounding, making it more vulnerable to nerve injury. Just like we have ulnar nerve entrapment neuropathy, the ulnar nerve should not be blocked at this region. It is either below elbow or above elbow. So ultrasound has changed the whole lot of scenario. Now we have ultrasound probes are available. We do a single shot block with, we all were discussing about sterility. We do follow standard guidelines with putting a tegaderm for a single shot block, and if I'm planning to put a continuous catheter, I might put sleeve and wash up. Median nerve block believe me, these blocks are very simple. Only thing is we never had training in our fellowship training or PG training, so we find it little bit out of the way. Now, important landmark for median nerve at elbow is nerve is medial to the artery. Here you can see nerve just lying on the medial side of brachial artery. We have to place the probe in elbow region, and here you can see the median nerve lying just by the side of brachial artery. It is very easy to identify. You can block nerve at this area. Now here is a short video which showed that artery, by the side of artery there is nerve. So it's absolutely very easy. We just have to think that we have to do it and we can really move. As far as radial nerve block, there is no vascular landmark, Probe should be placed between the groove between common extension tendon and the bicep muscle. Here you can see two muscles. The nerve divides into superficial and deep. We have to block the nerve just above the elbow. As you can see at the lateral margin of cubital fossa, you can feel for this groove in between the two muscles. We just have to place the probe there, and nerve is seen in between two muscles. It is very easy to identify. In plane technique, 5 to 8 ml of long-acting, maybe bupivacaine or ropivacaine for better post-op analgesia with or without adjuvant. Here you can see the scanning for this nerve, nicely seen. As you could trace it upward, as you tend to trace the nerve, you will see its division. So we can block it little bit above the elbow before it divides. Now for ulnar nerve we need to block from wrist. We need to trace it up. The important landmark, just like median nerve, is ulnar nerve is also medial to the artery. You can see this clippings, the artery in the center, and just by the side, on the medial side, is the ulnar nerve. The pulsating artery, very easy to identify. You can trace it up back in the forearm and block it. Sometimes we had problems with musculocutaneous, though in ultrasound era it is very difficult, but once in a while we need to know this anatomy as well. Previous speakers have dealt with that in great detail. As you see, the lateral side of forearm is with a cutaneous distribution from a branch of musculocutaneous, whereas medial side is from medial antebrachial cutaneous, which is not ulnar distribution. So we need to know this. The nerves supplying these area are emerging from cubital fossa, and they are superficial. Subcutaneous infiltration in this area, if needed once in a while, you need to know this so that you can supplement it. Now, wrist block, also an underused weapon. When patients under GA or when the block is done with a short-acting local anesthetic in a proximal block, then we can think of wrist block for post-op analgesia. Learning wrist block, we may or may not practice in our regular curriculum, but learning it will help us in understanding the anatomy and the distribution area of the radial nerve. So how it changed my perspective is, like, any time for any distal, any forearm surgery or wrist surgery, I would always look at X-ray of forearm, X-ray of wrist, where will be the incision. So I tend to correlate. So wrist block often is done with landmark technique. With ultrasound, it helps us to differentiate between tendon and nerve. You just have to trace the tendon backward, it merges into muscle, whereas you could identify nerve very easily. It continues to remain as nerve even in the forearm. So pre-medication is a must. We all have discussed the importance of pre-medication and use of PNS needle. And radial nerve at wrist block, it is a very simple block. We all know at a level of styloid process, just above the anatomical stump box, there is a radial styloid process, and subcutaneous infiltration in a fan-shaped manner, 3 to 5 ml, will cause radial nerve block. Median nerve block, important anatomy is along with relation with palmaris longus. It is just by the side on the lateral, just lateral to palmaris longus. How to identify this tendon is when we touch thumb with little finger and cause little flexion at wrist, then the palmaris longus becomes prominent. And just by the side of palmaris longus, between flexor carpi radialis, if we deposit drug in a fan-shaped manner, 3 to 5 ml, it causes good median nerve block. Nerve, if we have ultrasound here, we can trace the nerve back and confirm that it's nerve. Median nerve block with PNS, as you could see. Ulnar nerve block at wrist, we have already discussed that nerve is medial to artery. It is below the flexor carpi ulnaris tendon. Now, little radial deviation of hand causes this the flexor carpi ulnaris to become prominent. Local anesthetic deposited below this will definitely cause a good amount of block. We tend to use PNS needle. So in short, we have 3 nerves at forearm, 3 nerves down. For radial we don't have any vascular landmark. It is in between two muscles, but it can be easily identified with ultrasonography, can be combined with dual mode if we want to confirm that. But as far as median and ulnar nerve are considered, we can easily block them with vascular landmark. For wrist block, we need to know about palmaris longus identification, flexor carpi ulnaris, and radial styloid process. I think if we follow all this, and we have done with all sorts of upper limb block, so that brings to end of my presentation. So we are moving into era of safety, quality, and better patient satisfaction with ultrasound. Thank you so much.
Thank you, Dr. Dikshit. I would now like to invite Dr. Rashmi Chauhan Mehta to speak on intravenous regional anesthesia.
Okay. Good afternoon, ladies and gentlemen. By the time he changes the laptop, at this hour, when the hour shift from morning to afternoon, focus is now going to shift from the in-fashion nerve blocks, ultrasound-guided, nerve stimulant-guided, to a vintage classic block. You see, I'm a very nervous speaker. I'm even carrying my handwritten notes over here. So some positive response to a few questions of mine will buck me up. And please raise your hands as I ask the questions if you think you have the right answer. How many of you are practicing nerve blocks? Please raise your hands. How many of you are practicing ultrasound-guided nerve blocks? How many of you in future want to do ultrasound-guided nerve blocks? Wow. So that's a huge majority. And now how many of you practice intravenous regional anesthesia regularly in your regular practice? Oh, just look around, very few hands up. Just goes to show I have to work hard to make this block a little more popular. Well, this is a block which is of old vintage, circa 1908, when August Bayer, a German doctor, introduced it first. He was a surgeon, and his technique entailed using two tuniques, proximal and distal to the surgical side, doing a venous cut down, and then injecting some local anesthetic into the area to have an anesthetized feel, and do the surgery. 1912 or 13, the supraclavicular blocks came in, and well, Carl Bayer's technique got a silent burial. Morrison in 31 resurrected the block, and he modified it. He used a single tourniquet, and he had the venous access by percutaneous cannulation instead of a cut down, so it reduced the morbidity. Finally, in 1963, after a lot of years and a lot of modifications to the original IVRA described by Bayer, Holmes presented a series of cases in which he adapted the various modifications of over the years, which included prior determination of blood pressure so that the tunica pressures were set according to the blood pressure of the patient, careful exsanguination of the limb with edge mark and limb elevation, or both the procedures are one as required by the clinical condition. He also started using pneumatic tuniques, single cuff, double cuff, and he also he started using local infiltration under the cuff to avoid pressure pain of the tunique, and he was the first ones to use 0.5% lidocaine. And after incorporating all these changes in the block, he termed it Bayer's in memory of August Bayer, who initially started this block. All that you need as equipment, other than the basic monitoring and resuscitative equipment, for a good IVRA is a good tourniquet machine. This is a machine where you can see it's a computerized electronic digital machine with two cuffs. The cuff which you see at the back is a double bladder cuff, and the one in the front is a single bladder cuff. And the hoses which connect it to the tourniquet machine, and you can electronically control the pressures and the time in it. And besides that, that's about all that you need. And this is very little stuff which is required, which is there in every outpatient clinic, inpatient, OPD, anywhere else. So, nearly all surgeries in the forearm, distal to a cuff which can be tied on the arm, can be done under a bias block. Nearly everything can be done, except that there are a few contraindications to doing an IVRA. Something like allergy to the local anesthetic, patient refusal definitely, and certain medical conditions like sickle cell disease, Raynaud's phenomena, or if there's gross inflammation in the operative limb. There are certain relative contraindications like venous incompetence, cardiac blocks maybe. That's about all to it. Like any other patient, when we start off with a patient for IVRA, preoperative attending anesthetists know about it so that one can make them more comfortable with the cuff. We also can counsel them for the feedback so that we can detect local anesthetic toxicity. So we can ask them to get back to us in case they feel dizzy, tinnitus, circumvolar tingling, or some sort of palpitations. So this is the scheme of things. This meticulous attention to this sort of a scheme of things is all that is required in IVRA. We have to secure a tourniquet cuff, usually in the arm, double bladder cuff. It has to be well padded. Next is an IV axis with a small gauge. The more distally the IV axis is, the better the outcomes of the block with a small cannula. After that is exsanguination of the limb. Raise the limb, elevate it, use an edge mark. If you can't use an edge mark, only limb elevation, then limb elevation for a longer time. Inflate the distal cuff. Inflate the distal cuff when you're using two cuffs. Then you inflate the proximal cuff. This ensures that the entire venous system has been emptied out of the blood. After that, we deflate the distal cuff. We check for circulation. We still counter-check whether there's any pulse or anything. The tourniquets are working. There are no pulses. After that, we inject the drug. And then, once the block is there, numbness has set in, surgery can be started. And where it comes to the switch cuffs action, that can be done right at the beginning, in the middle of the surgery, towards the end, depending on when patient complains of tourniquet cuff pain. You want to wait till then, or you want to switch them over. In switching over, please remember we inflate the distal cuff first before we deflate the proximal cuff. Otherwise, we can have catastrophe. End of surgery, we deflate. We do not deflate before 20 minutes. That's the minimum, but I am more comfortable 30-35 minutes. You'll be safer, we'll not have local anesthetic toxicity. And after deflation, do monitor your patient for some time. It's not as deflation and out. No, please watch your patient. This is a small film. Of an IVRA being performed. This is a patient, 35-year-old male with a fracture distal and radius. And can you get the volume down? You can see we have padded the arm and we've got a tourniquet double bladder cuff.
Proximal and blue is distal.
As a standard protocol in my hospital, we have blue distal cuff, red proximal cuff. We get an IV axis. Over here we could not get it on the dorsum of the hand because of edema on the hand, so we took it on the forearm. We fix it. And after that, limb elevation. Mandatory at least 2 minutes. If you can do it for 5 minutes, still better. We have to support, in cases of fractures, we have to support the limb well because it is painful, movement is painful. So in this case, I had pre-medicated the patient with Midaz and fentanyl so that the patient does not have too much pain while we are putting the edge mark on. Once the edge mark is on, we inflate the distal cuff. So that's the distal cuff going up on the blue one. After that, we'll go up with the proximal cuff. That inflates the proximal one. You can take off the edge mark now. And then we deflate the distal cuff. So we only have the proximal cuff on now before we inject the medication. We check for the pulses. Rate of injection of the local anesthetic is very important. It has to be slow, 40 mils to go over at least 1.5 to 2 minutes. Initially give a small aliquot, wait, check for any bradycardia or anything, and then finally inject the whole thing. Theoretically, it says the pressures when you're injecting should not exceed 90 mm. The rate of injection has to be still slower if the cannula is nearer the tourniquet cuff, because otherwise you can have the deep veins through the bones transmitting the drug into the general systemic circulation. So slow injection is very important over here. Next important thing is to prevent a hematoma once you take off the IV cannula. So pressure, and maintain that pressure for at least a minute so that the drug will not leak out through this punctured vein, and wait for the effect of the block to come in. That's a patient all awake, comfortable. As you can see, the gauze on the venipuncture site is still there. This is at the time when I switched tourniquets, around 45 minutes. That's when the patient started complaining of tourniquet cuff pressure pain. And that's, if you would have noticed, it was the distal cuff which was on there and not the proximal. And this just goes to show you can do any type of surgery. This was a plating being done, and the surgery finished in 53 minutes or so. And once you deflate, please monitor. Look for bradycardia. Deflation can be done all at one go. In this patient, it was done all at one go. There was no drop in pulse rate or anything like that. But deflation can also be done cyclically. You do it, again, inflate that cuff, deflate again, inflate again, in 2 or 3 cycles like that over a period of 5 minutes, you'll be safer. The other way to deflate gradually or to have less effect is do it sequentially. There's another film, one short film. This is a variation of the same, sorry. That was a variation film which I was trying to show. This is a forearm cuff. We've used a forearm cuff over here. The advantage of it is that you use a lower volume of drug, and the advantage of using a low volume of drug is that I'll just go through it fast because my time's running out. You check the pulses, you give a low, if you inject only 20 mils with this cuff, and at the end of it, the hand movement is still there. The patient can still move their fingers though they are anesthetized. So a lot of hand surgeons doing tendon repairs and all would like to have their patient in that sort of a condition. Your time's up. Thank you.
Thank you. Thank you.
Thank you very much, Dr. Mehta. Moving on to our next sub-session, which is current evidence. Are interscalene brachial plexus catheters the preferred route for post-operative analgesia following shoulder arthroplasty? Well, the answer is going to be given to you by Dr. Shiv Kumar Singh from the United Kingdom.
Good afternoon, everyone. I think it's lunchtime, and they've given me a good topic to discuss. I work at the Royal Liverpool University Hospital. Greetings from Liverpool. And thank you to the organizers for inviting me here. I've met a few of my professors from AIMS, where I did my MD, and some from JIPMER. Manoj is my senior. And obviously the Facebook group, the anesthetist, people probably know me by the name of the anesthetist. They sometimes actually call me the anesthetist. We're also organizing a conference in November, and I wish all of you will be there. Now the topic is such that it's like asking to actually see Delhi in one day. Well, you would be stuck by the traffic, isn't it? You could probably not see all the monuments. You could actually have a glimpse. So that's what you're going to have. You're going to get a glimpse of what it means. Unfortunately, if you look at the literature, there isn't much about it. Well, you can see individuals comparing PCAs, comparing with single shots, but there is no comparison between a single shot and a continuous catheters. So it is looking like doing an RCT on whether parachutes are safe to jump. Or would you want to do RCT with parachutes? Probably not. Why do the patients actually come for arthroplasties? It's not a common surgery as is for hips and knees. It's very, very specialized area. And the reason being that with shoulder replacement, you have to get a whole range of movements, which they don't look for in hip and knee. You can actually get away with slight differences in movements. These patients actually have uncontrolled pain. There is loss of movement, which can consequently lead to the loss of function. Question is interscalene brachial plexus blocks the preferred route? Obviously, when you say, is it preferred route, we're obviously trying to see, are there other routes? Obviously, there are. And we need to compare them in terms of efficacy, in terms of safety, and in terms of outcomes. The incision is in deltopectoral groove. We cut through muscles. We ream through the bones. Okay, and the procedure can be quite extensive. There are different types of procedures. Okay, in some which there is reaming of the bones, others they can just be resurfacing. But the incision and the extent of surgery is not much different. And it's very, very important to know the course of the whole procedure. Okay, it's fine how did the surgery go, but what happens on day 1? What happens on day 2 or day 3? For example, on day 1, the surgeon would like to see your fingers, the wrist and elbow movements, which is actually needed for physiotherapy. Now, if you give a block and the patient can't move the limbs, like a very good block, then it's useless because you cannot proceed beyond day 1, so you have to wait for the block to recede. So you need something which gives you not only good pain relief, but also allows you to assess the motor function. So let's look at the good, bad, and the ugly of the analgesia for shoulder arthroplasties. First, looking at simple analgesics. Okay, you actually press the bell. Okay, you come to you got morphine and all kind of analgesics. You come to the ward. Okay, you ring the bell. Your nurse comes in. She goes and gets the painkiller. By then, your pain is shooting up. You get the pain relief, but now because your pain has gone up, you get a lot of painkillers, and then you start throwing up. You're sick. You never actually reach that level where you can actually be pain-free. Okay, so it's basically a roller coaster ride. Then we look at single shots. Single shot anesthesia is very, very popular among people, but unfortunately, you actually come out smiling, you sleep like a baby, and around 3 o'clock in the morning, you wake up howling with pain. And that's when the challenge is how to control that pain. And that's where the catheters comes in. So the first two are kind of a rejects. So catheters gives you a round-the-clock pain relief. You may not actually be at 0 level. You might be slightly above 0. You might have pain scores of 2 or 3. That can be managed with multimodal analgesia. So it gives you a wonderful pain relief throughout the clock. It gives you flexibility. Okay, if you have catheters, if the surgery goes beyond a certain extent, you can give a bolus. You can extend the analgesia. You can control whether you want to actually have motor effect or you want to actually have sensory effect. You can reduce the concentration. You do not require very highly concentrated solutions to have analgesia. So basically, you actually hit the nail on the head. So pain relief round the clock. Is there any evidence to it? If you look at the papers, most papers actually compare PCA with single shot, PCA with continuous catheters. There isn't much literature which actually deals directly with something like single shot versus the continuous catheters. Of which what comes to mind are these few papers, Singling's in 1999 paper which compared continuous infusion with PCA, obviously said, well, PCA required more analgesia. That's very obvious. Again, Elfield in 2003 and in 2006 tried to do the same thing. What they found out was that continuous blocks actually allows you for not only good pain relief, but allows you for early discharge as well. So they are very good. But are we there? Can everybody actually provide a continuous analgesia for these patients? A very painful surgery. There are actually challenges, okay? Yes, we need special kits for them. They are costly. You need skills, okay? You need to know how to do the blocks with ultrasound or with peripheral nerve stimulation. Do you have the skills and the resources? Do you have the facility to provide continuous analgesia using pumps? Okay, some of these can actually be programmed. Some can be simple ones like the balloons. Okay, these are the pneumatic ones. They're not cheap. They're not cheap. Okay, they do actually cost a bit. And the last thing, there are complications. Okay, do you know who that is? Superman, yes. Okay, he developed quadriplegia. Well, he didn't have a block. Okay, but there were two cases actually where by the posterior block, when you use ultrasound, you tend to go posteriorly. And it's very, very easy to actually cause nerve damage. So there were two cases of spinal cord injuries where a patient developed quadriplegia. And there's another one where a young professional actually came for a shoulder surgery, had a catheter put in. Everything went very well. Okay, day 1, day 2, day 3, day 4. Okay, day 5, the doctor came to take out the catheter, took out the thing, and there was sudden pain, rushing pain. The patient said it was like a bolt of energy going down the arm. The doctor said, oh, that's fine, that's okay. It doesn't matter. Took it out, and he had actually ripped out a superior cord. Okay, so this patient became, who was very productive, unproductive, couldn't use. And I can imagine how much that is going to cost them. So there are challenges to actually doing that. They are, yes, good. Okay, that's where that paper was. This is unpublished report. So in conclusion, are they good? Obviously, they are. Actually, that we have struck a deal. Okay, it is the best. Okay, the question is, can we all provide that? That is the biggest question. Okay, so any questions for me? Okay, you still got 2 minutes.
I think another round of applause to him for sticking to the timeline. Fantastic. We'll now move on to the pros and cons session. This is on regional anesthesia masks compartment syndrome. Speaking for this is Dr. Manoj Padman, who's from Gurgaon. He's the senior pediatric orthopedic surgeon at Fortis Memorial Research Institute. And immediately after speaking against this will be Dr. Senthil Sadashivam from the United States.
Good afternoon, everyone. First of all, I'm Manoj Padman. I'm a pediatric orthopedic surgeon. So talking to a whole bunch of anesthetists is a new experience. It's not every day that I get an opportunity like this. So I thank the organizers for inviting me. So this is something which I am kind of, I have strong views about it, as most orthopedic surgeons have about compartment syndrome. So, okay. So it's a pre-lunch session. Yep. Of course it does. Regional anesthesia masks compartment syndrome. That's the end of the debate. Let's go for lunch. Yep. That's the orthopedic view. And we don't encourage discussions and quite strong views about it. So you might say most orthopedic surgeons debate and discuss like this. It's like the blind leading the blind. Okay? But this is an anesthetic forum, so I need to kind of step up. So we all know just a few basics about compartment syndrome. Osteofacial compartment, tight compartment, reduced tissue perfusion as a result of either internal or external pressure. We all know all this. It triggers off an ischemia, reperfusion, ischemia cycle. And what we are worried about is this rapidly progressive and irreversible neurological and muscular dysfunction. That's what we want to avoid at all costs. Prompt diagnosis, the critical aspect is early diagnosis and immediate intervention by decompressing the facial compartments. There's no debate about all this. Now, we also know that any delay in diagnosis has catastrophic consequences. Despite whatever evidence might come about compartment pressures, the diagnosis essentially still remains clinical. Compartment pressure monitoring, one-off, is of no use. Continuous pressure monitoring is not acceptable and not practical for universal application. Other non-invasive modalities are evolving, but not yet out into the mainstream clinical practice. So the key to preventing and avoiding compartment syndrome is a high index of suspicion and early pickup. And a very good awareness of what are the clinical scenarios which are wherein one is likely to encounter compartment syndrome. So coming to this clinical diagnosis, I mean, what we are taught, I don't know what the anesthetic literature says, but is the 5 Ps, and of which pain takes precedence, being the first and foremost presentation as well as the most significant presentation. Not only does it have a temporal sequence, but sometimes all these presentations can manifest at the same time in a florid compartment syndrome, but pain precedes most of the time. The critical thing, as you can see, is that there is a cutoff, and when you start having paresthesia in an anesthetized limb, you are already entering into irreversible damage. So coming to, I'll just take a little bit of time to focus on the pain itself. Pain is reported to be disproportionate, severe. Increasing analgesic needs are often necessary, and it's worsened by passive muscle stretching. So what happens in this kind of a scenario? So you have the helpful anesthetist who takes care of the pain. Yeah? So if ever there was a perfect oxymoron, that's the helpful anesthetist. So coming back to the clinical situation, and you have a potentially evolving compartment syndrome with a helpful anesthetist. And as I mentioned, pain is the primary presentation. That's where you have to intervene. That's where you have the opportunity to address it before it becomes irreversible. That's been taken care of. So you don't have pain now. So you don't have the window of intervening before irreversible damage happens. Helpful anesthetist. So why the debate then? If it's as crystal clear as that. Now the problem is, I mean, looking through the literature, both anesthetic and orthopedic, pain as a diagnostic criteria raises a few shackles, simply because it's subjective, it's variable, it's an unreliable complaint, it's very poorly sensitive, and it doesn't have a great predictive value in terms of confirming diagnosis. My counter to that is, however flawed the clinical assessment is, that's the best that we've got. We don't have anything else to be more objective, so you have to rely on that. It has a high negative predictive value, in the sense absence of pain in an awake, conscious patient who's unanesthetized, absence of pain almost inevitably rules out compartment syndrome. And pain in the context of the clinical situation, wherein there is pain on passive stretch, plus some amount of subtle neurological dysfunction, is highly predictive of compartment syndrome. What about the evidence wherein linking regional anesthesia with compartment syndrome? There is no clear link to prove the association that there has been a delay in diagnosis because of regional anesthesia. Most of the evidence is level 3 evidence and poorly reported case reports which really don't document well enough what has been administered and when the symptoms started. But even then, given all the flaws, techniques which impair clinical evaluation, critical clinical evaluation, one has to kind of prove its clinical safety well beyond reasonable doubt to kind of put it into the mainstream. That's my argument. Because whatever be the quality of evidence, what you encounter in a limb which unfortunately ends up in compartment syndrome is something like this. And this is, believe me, this is a better outcome rather than losing the limb. But what we know also from the literature is that in case reports which have had compartment syndrome, there are plenty of missed opportunities to intervene. There is opportunity to kind of improve our level of clinical care in terms of better documentation and better monitoring, because a lot of the patients who went on to develop compartment syndrome had pain much before any kind of diagnosis was established. So the critical thing is awareness. So in conclusion, and I am quoting this from one of your newsletters, the current practice does not justify routine use of regional anesthesia, despite however flawed the clinical assessment is as a diagnostic tool, because that's what we have, that's the best that we've got. And so routine use of regional anesthesia following surgery on the leg or the arm in a patient who's at risk for acute compartment syndrome should be carefully considered. So I'll leave you to the next speaker.
I'm Senthil. It's nice to be back. Thank you for the invitation and the opportunity. And so if he concedes now, we all can go for lunch. Would you? No. Okay. So I know he's like old-fashioned orthopedician. So we know that all the audience are anesthesiologists, especially regional analgesia anesthetists. So we know that regional analgesia does not mask compartment syndrome. But we have an old-fashioned orthopedician, at least he's brave to come here to an anesthesiologist meeting. And I don't know that he's not caring or non-vigilant, but his patients will judge. And so he's still in 1980s and 90s. And so this significant problem in late 80s and 90s were the lack of awareness about compartment syndrome. The compartment syndrome happens because of pressure inside the compartment. He missed one important point, which is the 5 Ps. There are 6 Ps. The pressure is the first symptom. So we'll talk about that later. So inappropriate patient selection. So using high concentration of local anesthetic in a patient with multiple fracture with a swollen limb is not a good idea. And so we had to avoid. So we all learned, the anesthesiologists all are smart enough to learn. Still, there are some orthopedicians, they're in the old ways of thinking. Then also we talked about IV regional anesthesia in the past. Hypertonic saline was used. That led to a lot of compartment syndrome. Now we don't. So the improvement in the last decade, and we have better awareness, better suspicion, and better monitoring, especially the pressure monitors. And so we also are smart enough to select the right patient for our regional analgesia, and also we are good in selecting the right concentration of analgesics. And we use low concentration. So the catheters are the new way to go, as Shiv Kumar Singh talked about. It has added advantage, flexibility, and so we can lower the concentration. And we should not rely on pain alone, as our orthopedician pointed out. So early diagnosis and early decompression is important. The smart anesthesiologists may inform the orthopedician that there are signs of compartment syndrome, the pressure is building, there is firmness and tension in the limb, there is breakthrough pain. They may not intervene. Then finally, when the problem happens, they are good in ABC, not airway breathing circulation, but it's accusation, blaming, and criticism, right? So just we had to learn the pathophysiology of compartment syndrome. So ischemic pain is different from surgical pain. So it cannot be masked by regional analgesia. So you should not wait for pain alone, and you should not depend on pain alone to diagnose compartment syndrome. There are 6 Ps. So the most important and earliest he missed. So that's the pressure. The pressure builds up first before it compromises vascular perfusion. And so that's early and very objective, unlike pain, which is inconsistent, it's very subjective. And I work with children, they cannot even report pain. It's unreliable. As he mentioned, at least he accepted that it's a subjective and unreliable, and it has low sensitivity. So when there is problem, so when there is a pressure in the limb, so we had to do some pressure monitoring. There are a lot of methods. So these are not convenient for patients, but if you had to talk about the limb-saving procedure or life-saving sometimes, so it's worth monitoring pressure whenever there is a clinical suspicion. And the pressure cutoff is more than 30 millimeters of mercury. It's a clinical indication for fasciotomy. So there are other methods too, besides pain and pressure monitors. Pulse oximeter, it's a measure of perfusion. Near-infrared spectrometry is also a measure of perfusion. Ultrasound, laser Doppler. There are other modalities as well. So the recent literature evidence, overwhelmingly, even though they are all case reports, they support that compartment syndrome can be diagnosed even with good working regional analgesia. I'll share a couple of good evidences. The case report for with the infraclavicular catheter and ischemic pain was not affected by regional analgesia in a patient with infraclavicular catheter. And so even PCA with opiates can mask pain. So even they are blamed by our orthopedic colleagues for masking compartment syndrome. And so the key is low concentration of continuous peripheral nerve block, and so that will help with pain pain control, also a diagnosis of compartment syndrome. The concentrations we are talking about is about 0.1 to 0.2% ropivacaine with continuous infusion. The sensitivity of pain in diagnosing compartment syndrome is 19%, less than 20%. So another report, compartment syndrome can be diagnosed in time due to breakthrough pain despite continuous peripheral nerve block. And here there's a tibial shaft fracture, which is known for compartment syndromes, and it's not masked by regional analgesia. The pain was not masked by. Another case report, and femoral and sciatic nerve catheters for lower leg compartment syndrome. There's strong evidence to show that regional analgesia doesn't compromise. We need to be careful in evaluating these patients, and high index of suspicions are needed for timely diagnosis. I think even the emergency physicians agree that for femur fractures, they did a lot of femoral blocks, and they report that there are no compartment syndrome mismanagement, early diagnosis. This is the last evidence, I think, and even epidurals are blamed for compartment syndrome, and so prompt diagnosis is easily possible as long as we use lower concentrations of epidural, and also we have good monitoring of movement of legs frequently. And so I'll conclude with this slide. So recent literature evidence and our experience suggests that compartment syndrome can be reliably diagnosed while providing good pain control to our patients. And in addition, I have an offer to help our orthopedic colleagues. If you have a catheter, and we can even treat, provide decompression at bedside with, say, local higher concentration, say, chlorprocaine at bedside to do emergency fasciotomy before going to the OR, which will save time, so we can save limbs and lives. Hope we all learned, and including our orthopedic colleagues.
Thank you, Dr. Senthil. Now, audience have listened to both orthopedic surgeon as well as anesthesiologist. And you have something to say?
I think we both have a...
Yeah, okay, you go.
Because I mean, he's been very helpful, offering to help, the helpful anesthetist.
Yeah.
So, I mean, I do agree to the pressure bit. I deliberately chose not to mention it because most of orthopedic patients would have a bandage or a cast or a slab. So pressure goes out of the window unless you are pressing through the slab or, most of the time. So, yeah. So, I mean, old orthopedic surgeons, 70s, 80s, that's fine. I'm the modern generation. So there is an alternative view. So there's an alternative view. There's no doubt about it. But having said that, I mean, the evidence in favor for regional anesthesia is very tenuous at the moment. And I mean, this is, I mean, despite all my reservations, I mean, in my practice, I use a lot of this. So that's by the by. But from my perspective, in an orthopedic forum, the amount of resistance to regional anesthesia is unbelievable. So you can have your meetings and you can have your this thing said, but in the same forum, in our national meeting a year ago, I was just shouted down to say, all you need is one case of compartment syndrome to change your practice, to define your practice. So we have to move beyond case reports, which is where the evidence is. Okay. So what is the way forward? What is the alternative way? Having listened to Dr. Senthil's evidence and offer of help. So we all agree, we need post-operative analgesia. There's no doubt about it. And we don't want our patients, especially, I do pediatric orthopedics, I don't want my children to be in pain at the end of it. There is a genuine risk of compartment syndrome. You cannot wish it away. You cannot say that this is hype, this is, there is a genuine risk. And if it happens in your practice, it will change your practice for better or for worse. Yeah. Can we improve our practice? Definitely. So I think you have to move beyond what you do in the operating room. And can we minimize risks? And this is what I'll just focus on in the next couple of minutes. So we all want a perfect solution, yeah? So that's not there. So what's the way forward? So the awareness of at-risk scenarios. So you can't lump all, all extremity surgery into one, because definitely there is a huge amount of risk. You can have a femoral nerve block for a femoral shaft fracture. The risk of compartment syndrome, yes, it is there, but it's much lesser than in a tibial fracture or a forearm fracture. So it's complete. I have no issues, the emergency physicians giving femoral nerve block left, right, and center. The chance of compartment syndrome is much lesser there. So extremes of ages who cannot kind of voice their pain and things like that, comorbidities. The anatomy matters, Are you doing leg work? Are you doing work on the tibia? Or is it the forearm? These are the main osteofacial compartments. Substantial numbers of compartment syndromes are reported from these two anatomic locations. You will have the odd gluteal compartment syndrome following, X block or Y block, but that's different. Unilateral, bilateral surgery matters. Type of surgery matters. Is it emergency? The duration, the position. And you'll agree with that. I'm being reasonable. I'm a reasonable orthopedic surgeon. Yeah? So trauma, polytrauma, head injury, these things matter. Surgical procedures matter. Is it a close nailing that you're doing? Are you doing percutaneous osteotomies? Some of the deformities that I correct are massive corrections, and that puts the soft tissues at strain. So you have to factor all of that in. Okay, so I'm glad Dr. Senthil mentioned about the ABC. That's again the old anesthetic. What was it? C was for ABC. Criticism. Now look at the modern orthopedic surgeon. A for awareness. Yeah. B for we need to get better at. I'm progressive. You need to assess the risk. That's the. You need to have robust monitoring. We need to get better at that. We need to be much more, thorough about evaluating, not just in even in our post-op wards. We need to document, because most of the case reports do not they're not able to make that link between regional anesthesia simply because there's no documentation of what's been administered. Our techniques need to be refined. You'll agree with that. The drugs and dosages, you need to dilute the stuff whatever you want. You need to titrate it. You need to time it. You need to educate. So you need to get better. So this is the modern A, B, and the C. Yeah, there's a clinical risk management. So I'm not criticizing anyone. So you need to have your checks and balances in place before offering regional anesthesia for everyone walking through my door. Yep. You need to have your protocols in place about how you're going to do the monitoring. Are you going to rely on somebody pressing through a slab for pressure checking? This is 2014. We don't do that in Delhi and Gurgaon. I don't know what you do in Cincinnati. You need to have your trigger points to kind of escalate to the next level. And two things I'll just touch upon: caution and communication. And that's a personal thing. Okay, so this is just this thing. Now, I've seen a lot of anesthetists who are who come with this. Have needle and probe, so we'll block now. It scares me, scares the living daylights out of me, irrespective of whether the patient needs that level of pain control post-operative. I've done a simple procedure, and now I've got a needle and a new probe. I've attended the Aora 214, and they've told me all the nerves that can be blocked. It scares the living daylights out. So there's a bit of caution there, So surgeons have to kind of put their foot down sometimes. And also communication helps in terms of it's a two-way communication. So we can't be like this. Yeah? So I agree. Orthopedic surgeons have a lot of fear, paranoia about compartment syndrome. There's no doubt about it. What I find in my interaction with anesthetists that the anesthetic side, there is a bit of reluctance to acknowledge the concern. And they tend to trivialize our compartment syndrome. That's fine, no big deal. We've got our pressure monitors. This thing. That's not the case. So it's not a simple, you know the results today. It's not simple yes or no. Shiv, what's happening? You're now in England or UK? So there you go. So if we come back again to the helpful anesthetist for the perfect solution. Yeah, this is what we want. We're simple people, orthopedic surgeons. Just block whatever you want so that you're not going to take me to the courts. Thank you. So, by the way, you're all reasonable people. I think there is a vote which will be this thing. Don't vote like this. Yeah? So,
yeah, it's a nice try. So one thing he did was he acknowledged that he doesn't say, he preaches, but he doesn't practice. So he allows regional analgesia for his patients. So don't believe whatever he preached. That's the first thing. And even though he's not old, but he is old-fashioned. That's what I meant. And so one thing he's good at is, so at least he recognizes the problem. So if you don't immediately intervene. Say in 30 minutes, nerve will dysfunction. In 2 to 4 hours, the muscle will dysfunction. Muscle necrosis have been reported in 4 hours. So you had to move faster. So I'll skip this one. So there are a lot of evidences from beer block, from hypertonic saline. At least he's not using that, which is a good thing. And so poor patient selection. This is the most important key. We all agree that all anesthesiologists are in favor of not doing, say, regional analgesia in a patient with high risk. Who are at high risk? Patient with, say, multiple fractures, swollen leg, and low blood pressure. And these all will compromise, say, compartment, perfusion. So we will not be even offering block. So he's talking to somebody else. I don't know whether his orthopedic colleague or not. At least he's talking to his senior orthopedic colleagues still. So that's why he's not changing, even though he's modern. So low index of suspicion. Sometimes we had to have very high indices of suspicion. In our hospital, sometimes orthopedic surgeons don't even come after operating on these patients. So if they don't see the patient, even if anesthesiologists, helpful anesthesiologists appoint to, then if they don't show up, then they will contribute to the delay and delay in intervention and decompression. That leads to a lot more damage, and the damage he showed. He should get the advice from a helpful anesthesiologist and immediately intervene. He should not wait and talk to his senior colleagues. And so there are a couple of reports. They've chosen a wrong patient, so a hemiplegic patient on warfarin, to use block. So that's not ideal. That's in 1980, so this paper was in the 80s. So we all learned from that. So hopefully our orthopedic colleagues will also learn and improve their care. So he talked about splints, what we do in Cincinnati. And we do even continuous monitoring at bedside in the floor setting while patients have nerve catheters. And so we managed pain while the patient was having compartment syndrome with continuous nerve catheters. Or at least surgeons were very flexible in taking the splint out to relieving the pressure. And they took the patient at least 2-3 times to measure the pressure and do decompressive fasciotomies. And so I will conclude like this. So with better awareness, better patient selection, and better monitoring, including pressure monitoring, which is inconvenient for orthopedic surgeon, but it is life-saving for, limb-saving for patients. And so to our anesthesiologist's advantage, we have to use lower concentration of local anesthetics to facilitate early diagnosis and immediate intervention. So our experience and available evidence suggests strongly that compartment syndrome can still be diagnosed early, and also the patient will be a lot more comfortable and with the regional analgesia than any other methods. I'll stop right there.
So, do you agree with Dr. Santhil's justification? After all, yes. Anyway, what is the public opinion? Let's ask the people, without getting biased for the surgeon. Should we use regional anesthesia block for patients for upper extremity and lower extremity? Yes. And no? How many of no? So there are 4 yes and nobody no.
I think they are a bit reluctant to put their hands up in case the others say that. I thoroughly enjoyed your debate. I think a round of applause for that. I think I have attended many meetings on this topic, and I think it has been sensational. Senthil, Manoj, it was greatly done. But I need to make a few comments, not saying that I'm on his side or your side, but I think what you highlight in your rebuttal is very important, that it has to be individualized. There is nothing like one shoe fits everything. You have to work as a team. So the occasional orthopedic anesthesiologist going to anesthetize a pediatric child with a major orthopedic limb trauma is not to be acceptable anymore. I'm sure you do that in Gurgaon, you do that in Cincinnati. So that is the very important message that each and every one of us should take home. monitoring is very limited. We have very limited, and you alluded to the fact. Certainly they have costs, but I think in many centers, including ours, they make a little window where you, and now doctor is now acknowledging the fact. Now, pulse, monitoring the pulse is very, very limited too. What do you feel a pulse? It's very difficult. You use oximetry, you use pressure monitoring, it's very non-sensitive. We use laser Doppler. How many people have access to laser Doppler? Very few. I would think that we must learn to do pulse wave Doppler sonography. Now, I have a message for you here because this is something that even I can do it, you can do it. That's the message. Now, what do you see in a pulse wave Doppler? Not many anesthesiologists today use it, but it's a tool that's available to you. It's also available to orthopedic surgeons because they do MSK sonography, in your day-to-day practice in many centers. Now, when you look at an upper extremity pulse wave Doppler sonography, it is a triphasic waveform. I hope you understand what I'm saying. During systole, there is a peak. During diastole, there is a peak. Blood flow occurring within the blood system. During the protodiastolic phase of the cardiac cycle, there is a negative cycle. So you have a positive, a negative, and then a positive. When you do regional anesthesia, the first thing to disappear, now if often you ask, when you monitor a patient, what signs do you look for? Even anesthesia, we look for loss of sensation, we look for loss of temperature. These are way, way, way later. If you were to do a pulse width Doppler, the first thing you will see is reversal of that negative cycle flow, the diastolic flow, the protodiastolic flow. So you will see a positive followed by another positive. And as the block establishes, it becomes, the diastolic flow becomes a biphasic waveform. Now, I don't say that this is a continuous monitor, but it is an intermittent monitor. In the event that you have alteration in perfusion to that limb with an ongoing block in place, you will see reversal back again. It will show you that what the reversal shows is that there is an increase in afterload, either because of compression, either because of thrombosis. So I would urge you to learn how